Okay, and we're live. So, hello everybody. Welcome to this roundtable at my channel. If you haven't already, please go subscribe and hit that red button. So there is Rob. Okay, just in time. Welcome, Rob. Can you hear us?
Hello, how are you guys?
Hi, Rob. Welcome.
How are you doing?
Good. How are you, Russ?
Okay, good to see you. Good to meet you for the first time.
Likewise.
Okay, so both welcome to the TOT Doctors Roundtable. For the first time here, Dr. Rob Kominiarek, is that the right pronunciation of your name?
Yeah, if you want to do it like the Polish way, it's Kominiarek.
Kominiarek?
Kominiarek, but yeah, Kominiarek, right. My grandmother would be yelling.
Okay, well, I'm not, well, I'm not so far from Poland here in Belgium. Okay, so both of you, welcome to the channel.
Thanks for
Hey,
having
everybody.
me.
Okay, so let's do this. So since it's your first time here, Rob, can you maybe tell us and the viewers a bit how you got to be a doctor specialized in optimizing hormones? What was your original specialization or your original goal when you studied medicine?
So that's a good question, right? Like, how did we get into this? So it was years ago, actually. I started out in family medicine and emergency medicine, and it was 1996, 1997. I was opening an urgent care in a farming community and was literally shaking hands with the administrators. They're hanging up the sign, and a car pulled out in front of a motorcycle, and the motorcycle skipped off the A pillar of the car and ran out there with the trauma pack and packed this kid up. And helicopter came in and we sent him off to the trauma center, and he obviously fractured his pelvis. There was blood everywhere. His jeans were ripped apart. Didn't think anything of it. Maybe 6-7 months goes by, and this same kid showed up in my urgent care, complaining of fatigue, exhaustion, just not feeling good. And the first time I met with him, we ran laboratory on him and really didn't put one and one together. Didn't know who he was. Didn't say anything about his accident. And in the second meeting, we talked, and I find out, hey, this was the kid that skipped off the A pillar of the car. And when he did that, he left one of his testicles on the road, and the other testicle had to be removed in surgery. So I sat here and went, oh, so this guy's not making any testosterone. And when we did residency, there were 3 chapters on female reproductive health. Well, there was a paragraph in the textbook, and all it talked about was prostate cancer, and if you had no testosterone, 200 milligrams IM every 2 weeks. That was it. Well, I got on the phone and I called the urologist and I said, hey, you're the urologist that took off this kid's testicle. I guess I got to get him testosterone. Do you do that? And he goes, no, I don't do that. And he hangs up.
Nice.
So I call an endocrinologist and I go, hey, I've got a guy, he's got no testosterone. Like, I just want to double check what I'm supposed to do because that's all the book says, right? And this is no internet, right? This is before the internet. It's just kind of still dial-up just started. He goes, 200 milligrams IM every 2 weeks, click. I'm like, all right. So I give him 200 milligrams. 2 weeks goes by, I feel good, I feel bad. I feel good, I feel bad. I feel good, I feel bad. And that's how it all started. I would go to the library and I'd open up books and go, there's got to be something more to this. This kid feels good for a couple of days, then he feels like crap. I mean, this has got to be a terrible way to live. And that's how it all got started back in, 96, 97. And it's been an adventure ever since then.
Okay, very interesting. And so now you're doing just that, only the hormone optimization?
Yeah, so I've been doing hormones now since, 96, 97. And then along in the early 2000s came the Women's Health Initiative, which scared the crap out of everybody, doctors, patients, the whole bit. But was delivering hormones inside the insurance environment. pellets, injections, pills, patches. I've tried it all. And then 7 years ago, I closed my family medicine office and just started doing purely hormones in a non-insurance based environment. So out of that entanglement where we could actually treat people without having to battle insurance companies to get approval for things.
Agree. Okay, thanks for giving us your background. And as you know, Rob, I'm a big proponent of using the transscrotal test cream as the delivery method for TRT, as often presented and prescribed by my friend Dr. Keith Nichols. And I made several videos on that. And I noticed in the past that you had some remarks on the videos I published about that. And I was curious, actually, don't you like that way of delivery, or do you have bad experiences with it? What's about?
No, quite the opposite. Scrotal application of cream is my favorite delivery system. So it's my preferred method and has been for quite some time, using various concentrations. You name a delivery system, I've tried it. I've used it. My favorite would be scrotal application of creams. Next would be injections. But I prefer bioidentical over any other methodology. For about 8 years, I did pellets for quite some time. Then he just came to the conclusion this is not really the right way to go. It's just not physiologic. Though any doctor can make any delivery system work, whether it's injections, patches, pills, creams, pellets. In my opinion, that's not my favorite delivery system. And so the majority of clients are either creams or injections. And most of those injections are sub-Q, but I still do have some that like to do IM injections as well.
Here in Belgium and in most countries in Europe, we only have these long ester mixes like Sustanon, and a lot of people get these bad reactions when inject them subcutaneously. So we don't have just one testosterone ester. So do you have any experience with those mixes?
No, I don't use any of the long acting formulations at all. I personally keep tisipionate, propionate, and anthate. And the creams, probably, I'd say creams, Lipiderm base, or Versa-based cream. Maybe 70% of my clients are on scrotal cream. I've been doing this for over 20 years now. And so there's those guys that have been on injections for 10, 15, 20 years. If you like them, they're going to stay on them. But my preference is bioidentical.
Okay, agree.
Over synthetic.
Okay, and I don't know if you saw the previous podcast we did. Russ was on it as well, together with Dr. Jim Meehan. And Dr. Jim Meehan talked about the need to measure DHT when giving transscrotal testosterone cream, and maybe the long-term effects or danger of the high DHT. Do you measure DHT actually?
I do, but I really don't care what it is.
Okay, so I heard the reply. So why do you do it if you don't going to change anything about it?
That has to do with medical, political, legal reasons.
Okay. And that goes the same for estrogen?
The state of the environment that we're in requires that you be looking at labs. I mean, from a medical legal perspective, if you ever had your charts audited or ever ended up in some kind of environment that required you to have that, not having it isn't going to look good. So the opposite of that would be bad.
Okay, I understand.
But I can tell you personally, do I care what it is? No, I don't care what it is. Very rarely, every once in a blue moon, I might have a client, and they're always outliers. But, if you look at the data and what the studies show, and I'm sure Russ has read these as well, high levels of DHT are not counterproductive to prostatic function in any way. Every once in a while, you'll get an outlier, somebody that's had, significant issues with their prostate, that you'll ramp up their levels and they do have an issue. I had one guy that had a bicycle company in China, and he started his transscrotal cream, just an association. I can't say that it was definitely that, but he traveled to China, got there, was dealing with his company. And while I was there, his prostate got so swollen, he had an urinary obstruction. And you can laugh about it now, but at the time, I'm sure it wasn't funny. But nobody spoke English, and he couldn't get across to people that he needed to get to the hospital to be catheterized because he couldn't pee. And it got to the point where he literally, when he finally found a hospital, because even the cab drivers didn't understand what he wanted, when he got to the hospital, he had to pull his penis out and do one of these maneuvers, like put something in it so I can urinate. And he ended up flying back home with an indwelling catheter and a bag on his leg because his prostate was so swollen. Now, was that the cause of it? The literature would say no, but it was certainly the timing of it, right? Starting it, traveling it, and then this occurring, you have to wonder. So, we stopped the transscrotal application, let his DHT levels come down. And then we revisited a little bit later after he had a transurethral resection of the prostate. So,
What we found, Rob, you find this interesting. I deal with a lot of outliers and a lot of cyclists and endurance athletes, and we found this about 7 years back. And like you said, the doctor's toolbox is so important. And I think collectively, when we brainstorm, cream rises to the surface. The chamois, Rob, that's in the cycling pants?
Mm-hmm. Yeah.
They used to use a chemical softener to make that chamois more pliable, so you'd be fitted to the bike seat better. And that chemical was right against the testicles for hours at a time. And we found, a lot of high levels of estrogen and other, even DNA damage in some cases, when we think it was because of that chemical that was against the chamois. So, a lot of times we don't think about the external environment. And since I deal with the outliers a lot of times, I'm sort of a little biased because I'm always checking everything, because by the time they get to me, they've already been to 4 docs. So I want to make sure that I drill down correctly. But interesting though,
Yeah, I would definitely agree with that. My whole practice really over the years has not been built on starting people on therapy. It's correcting the issues after they've started therapy.
There you go. Yeah, great.
So like you, Russ, I get many patients that have been to 3, 4, 5 doctors, and things aren't working the way they're supposed to. And that's one of the fallacies about hormone replacement therapy. And we'll keep it strictly to testosterone replacement. This thought that testosterone is innocuous and any man can take it and it's going to solve any man's problems is really false. There are going to be those clients, those patients that don't do well on therapy, regardless of how it's delivered. You can almost put men into 4 groups. Group 1, they'll take it and it's life-changing. Everything in the world is better. And they'll want to get on top of a mountain and scream it to the world. Every man needs to be on testosterone therapy. It'll fix all your problems. Then you have group 2. They'll go on it and they'll feel better and it resolves their symptoms, but it's not life-changing, but it's good. Things are better. Then you have group 3, which really they're on it and they don't notice a difference. They don't really feel any great symptom resolution. It doesn't matter how high, how low, or intermediate we take their numbers. It's just kind of like, yeah, all right. Then you have the 4th group, and that 4th group is the one that always seems to have all the unwanted side effects. They'll have the erythrocytosis, they'll have prostate issues, they'll have edema issues, they'll have acne issues, they'll get anxiety, panic attacks, they'll have all kinds of problems. And generally, these are the men that usually require therapy. They'll have usually the lowest levels that you've seen, but they just don't do well and they're problematic. And those are the men that we get quite a bit. We see quite often. So I think there's things that are yet known to us that are starting to come to light as more genetic testing is becoming available as to why this subgroup of men just don't do well on therapy. And no matter what you try, sometimes the only thing you can do is actually pull them off therapy. and they can be difficult to deal with. And that's the vast majority of our patient population. So you get a lot of these men that have tried different therapies. And it takes some experimentation, playing with concentrations, whether it's a 20%, 15%, 10%, even down to 2.5%, which we use a 2% in women. But I've had some men, we've had to use a 2.5% concentration of cream so that they wouldn't have any unwanted symptoms, but could resolve their erectile quality issues or energy issues or strength or fatigue issues.
Okay, wonderful. So let's switch to another topic. Those are the phosphodiesterase type 4 inhibitors like tadalafil, Cialis. Are they helpful in erectile dysfunction, benign prostate hypertrophy, and anti-aging? Russ, what is your experience with it?
I think it's going to be very popular. There's some double clinical trials being done right now. I've been studying cardiovascular disease and what really blocks the arteries, whether it's soft plaque or calcium, for like 30 years. I do believe that the tadalafil, testosterone, and elevating the thyroid is going to be able to help put the brakes on endothelial dysfunction. And if you think about it, I'm not just talking about the coronary arteries that surround the heart, but the arteries that go to the brain too. So I think these, I work with heart patients, stent patients, I work with transplant patients. Just try to get a cardiologist to talk about testosterone. It's not going to happen. So a lot of times I've got to navigate this scenario like Rob said. But yes, I think it's going to be very, very popular. If you could maintain your endothelial dysfunction and keep it strong, and these, the tadalafil, testosterone, thyroid combination, you just got to have a good toolbox. I think that's just going to keep our cardiovascular system functioning, well into our 80s and 90s. I really believe that.
That's good stuff that Russ was talking about, and I'm gonna actually show you a graphic so that you can make this real for anybody that's watching this. And what I'm going to show you here is the inside of a human artery. So what you're looking at here is the glycocalyx. And for the people watching who don't know, you can see the endothelial lining, but this hair-like substance right here is actually the glycocalyx. This is actually the gel, and it actually protects the inside of our arteries. And like, here's the endothelial lining here. Well, with Cialis and all these medications that increase nitric oxide production, it helps to repair and keep this glycocalyx healthy. When we see individuals that eat too much sugar, so here's healthy glycocalyx, and they eat too much sugar, this is what happens to the glycocalyx. It gets denuded immediately after consumption. This is why high sugar diets are so bad. And this destroys that first lining of protection of that vascular endothelium that Russ is talking about. And a lot of people don't know what the inside of their arteries really look like. And this helps kind of drive things home as to why you need to eat healthful foods, decrease sugar consumption, stay away from a lot of processed foods, so you can maintain this healthy glycocalyx. And medications like tadalafil, which help increase nitric oxide, help maintain this healthy glycocalyx.
Yeah, Rob, that's amazing, man. I'm so glad you showed that. Right on. What I had to develop for some of the athletes, and I think this paints a picture: high carbohydrate diet, high sugar with the triathletes, marathon runners, impacting the glycocalyx, and then the imbalance in the microbiome, low testosterone from high mileage. I've got marathon runners and some triathletes that have had heart attacks and stents put in. So what I did, Rob, the same thing. I developed a restenosis program for the cardiologist, because when you put new arteries into the heart or you put a stent in, that damages the glycocalyx, like you said. So we have to do, sometimes that restenosis can happen in 6 months. So I tried to pitch this to 5 cardiologists and they got it, but they never pulled the trigger on aftercare program, so it's just good to see that you're all over that, man. I appreciate it.
That's important stuff. So medications like tadalafil, not only helpful for those reasons, but just from a purely kind of selfish standpoint, if you've ever taken sublingual tadalafil and gone to the gym, you know you get a fantastic pump from all the blood flow to your muscles. So it's always great to go to the gym, take a little sublingual tadalafil, and then do the biceps, and stand in the mirror afterwards and go, "Gosh, look at those things."
And what doses are you guys talking about? Is that 5 milligrams a day?
That's what I use, 5 milligrams. For people with lower blood pressure, I like 2.5 milligrams sublingual.
I use 5 milligrams with my docs. We've got patients right now with a calcium score of 1,000, 1,400. So we'll be getting scans done pretty soon just to see what impact this personalized protocol has. And like, you know, like Rob said, this isn't for every, you know, the biggest thing we have is time. When you spend time with somebody and you're dropped into the second act of a third act play. So we can't use any sweeping generalizations. We just got to have a big toolbox, you know, with the science behind us and our years in the business. Like Rob said, he's been doing this 20 years. He's going to have a lot more to look at than somebody over here at a low T clinic that's pumping, you know, turning and burning, you know, testosterone to these guys, you know?
Yeah. No, not a fan of those places.
No, it's terrible what's going on.
And talking about cardiovascular health and anti-aging, do you also recommend low-dose aspirin to all the patients as a primary prevention, Rob?
No, I do not. If you look at the studies, some studies will show it's actually not beneficial. The other issue that you have is that in some patients, while you may be helping, you're actually increasing the risk of GI bleeding if they have a predisposition from other issues. And then you're also increasing the risk of hemorrhagic stroke by about 30%. So while that therapy might be good for some patients, it's not good for all patients. And to use it in primary prevention, so in other words, you've not had any kind of episodes, I really wouldn't advise it in a healthy individual. Somebody who's had a heart attack or stroke, you know, that's been ischemic in nature, yes, it may be. So, but it really needs to be individualized. And that goes for any therapy.
Right.
And it doesn't matter what it is. It really needs to be individualized. You'll hear people talk about different protocols on the podcasts, and it always makes me laugh. Russ, you've been doing this for what, 20 plus years, right? I've been doing this will be my 24th year right now. And I would consider us all, Steve, I don't know how long you've been doing this, I would consider us all experts in this field. I'm not my own doctor. I have 4 or 5 doctors that I bounce things off of. I don't even treat myself. And I'm an expert in this area. And I use my experts, people that I know, to help me with my own health. So I don't write my own prescriptions. I don't take my own medications. I bounce that off of other people. And when I see individuals online taking recommendations off of Facebook and trying to fine tune their health based on what somebody else is doing, it's really inappropriate. And it can also be dangerous because everyone's an individual. There are so many nuances that you pick up in an examination and a consultation with an individual as to what their goals are, what their true health is, and what they're trying to accomplish in the end. And all those nuances have to be taken into consideration. It's not something that can be done simply on the internet by reading posts from other individuals.
Okay, sure. Nothing to add there, Russ? You agree?
No. I've been, like I said, I stay in the background. I've trained docs for a lot of years. My hardest thing for them to wrap their head around, and listen, I respect everybody, but I tend to piss people off. I don't know why sometimes. Everybody's biochemically unique. You got to have a big toolbox, right? Everybody's biochemically unique. You can't use sweeping generalizations. And like Rob said, some people are going to have inborn errors in metabolism and throw you a complete curveball.
Mm-hmm. Okay, sure.
Absolutely agree.
So
Russ is right. You really, that's one of the issues like he brought up earlier about places like the low T centers or whatever they're called, and these mills that pop up. They're based on protocols. Many of them are not medical protocols. It's bodybuilding protocols, which is just irresponsible. And in the long run, do more harm than good. I can't tell you the number of patients that we've had come in that have been to these places, and we see what they've been put on, and it's just inappropriate. It's not hormone replacement therapy. It's some form of a bodybuilding protocol or itineration of some protocol that's really pretty much designed just to sell product to people. It has nothing really to do with their healthcare, or it's insurance based, and it's based on how many injections and office visits they can have each month, and they can be billed to the insurance company. So.
Okay, let's talk about some things that I'm curious about, and a lot of viewers, things that in daily life could lower one's testosterone. Everyone is always discussing things like that. So I'm just gonna name a few and then ask your opinion on those. So things that are very often told to lower one's testosterone is soy, of course, alcohol, sugary drinks, licorice, then the phytoestrogens and cosmetics and soaps, flaxseeds, meat. The question is soy or corn-fed meat, and then even caffeine, energy drinks like pre-workout stimulants. So what's your opinion on those products? Are there any things that we really should avoid in daily life, Rob?
Those are all really good points. If you've read Anthony Jay's book, Estrogeneration, it's a great book. Does a good job at laying out which estrogens, estrogen-like chemicals that are out there that you need to try and avoid. It was a great book. I learned quite a bit from it. And then I took that information, I went through my own diet. I'm like, is there anything else that I could remove so I'm not taking in any of these phytoestrogens? I don't do soy. And I actually took a look. I had this thing. I like to make these pancakes in the morning, right? So not every morning, like once a week, I would make these pancakes. And in my mind, they were healthy, right? So I had this omega-3 powder mix, and I would use eggs and some blueberries, and I forget what else I put in it. And I thought, let me check this product to see what it's made of, just to make sure, right? And I go to the label of the product, and it was just flax. And I started laughing because, holy crap, every Sunday morning, I'm literally making and eating estrogen cakes. And it was good. I liked them. But after I read Anthony Jay's book, I was like, holy shit, I got to stop eating these things. Like, I'm going to start growing man boobs if I'm not careful. So yeah, if you haven't read Anthony's book, Estrogeneration, it'll give you everything you need to know about which ones you need to avoid. Soy and flax being at the top of the list. And the other one that was interesting was black bean paste that you'll find in Asian foods, particularly, especially like Korean and Chinese foods. And so I didn't realize black bean paste had that high of an estrogenic quality to it. Not that I eat that much Chinese food because the MSG always makes me sick, but yeah, good book. You should read it.
Yeah. Russ, do you give dietary recommendations to your clients?
Yeah. I cover the spectrum. I'm consulting in addiction centers right now, and a lot of my executive clients, they want to keep drinking. So they said, what can I do? So I go, well, it's not good. It's going to elevate estrogen levels, but you could switch from the liquid bread, the beer, and move over towards, vodka, whiskey, something that's take a page out of the drinking man's diet from 1950. That was an era where they ate basically a higher protein diet, and they were able to drink and still drop a few pounds. I'm not saying that for everybody, but people socialize. I've got executives that have to meet, and they do want to consume alcohol. So first thing we do is like Rob said, get them off the sugar. Move them more towards the ketogenic diet if they could handle it, if they don't need that carbohydrate serotonin burst or poor man's Prozac. And then we shift them from beer, over to a different drink, which is, all this is behavioral change. This is the pain in the ass of the business. You've got to work with these people. And the guys I deal with all have my cell phone. So you can imagine I got to talk them off the ledge a lot of times. But a clean diet, I mean, come on, a clean diet, anything that you can remove from the body burden, any kind of chemical you put on the skin, like Rob said, it's just a process. So I try to drip it on people slowly, because if you tell everybody this, And then they've got low T and they're feeling like shit anyway. You're going to overwhelm them. So I try to go slow. You know, I try to, you know, have them do, you know, I try to transfer learning to behavior like over 90 days. And Rob, I don't know about you, but once I get them compliant with whatever it is, a light's at the end of the tunnel, and they say, you know, I really felt like exercising today. When somebody tells me that, I'm like, okay, the behavior's changing.
Yeah, I would agree. We never come out of the gate charging ahead with everything because it's going to fail.
Right.
So you can get them taking supplements first and their hormones, then trying to eat cleaner. Exercise is usually the last thing we add. We'll try usually just walking at first.
Right.
When it comes to alcohol, you know, my personal views on alcohol, it's a toxin. I don't care what study you pull out. It's going to be detrimental to your health goals. For those guys that need to be able to, you know, especially the business guys, like you mentioned, Russ, I tell them, blame it on me. Say, hey, listen, you saw your doctor told me I can't drink because of my liver inflammation. Blame it on me. Put all the weight on me. Let me take it.
That's a good one. I like that.
The other thing I do is this. I tell them club soda with a lime.
There you go.
Yeah. The other thing is I have them they said, if you got a favorite watering hole that you go to, have a discussion with your bartender and tell your bartender, my drink is vodka club soda with a lime. But when I say vodka club soda with a lime, just make it club soda. Let everybody think I'm drinking vodka. Right? So it takes the social pressure off. Frank Sinatra.
Yeah,
Frank Sinatra was big on that. That's how he looked like a big drinker. He would play this little game. He would have his one bartender, he would take 2 sips, but he would slide the glass over to him, and they would always give him a fresh glass. So he never was drinking the whole drink. So it made him look like he could handle his liquor. So, and sometimes you got to do these little things just to take the social pressure off for these business guys who have, you know, 2, 3, 4 meetings a week, every
right.
killing them, right? These big meals with all this rich food and the alcohol, and it's usually a problem. So I like to give them little tools that they can use to try and help alleviate that. Because eventually, once they kind of get going, then they want to decrease it. I mean, you guys know, you'll get these guys that are drinking 6, 7, 8 drinks a night, and it can take a year to finally get them to the point where they realize, hey, I got to give this up. I got to give it up entirely if I want to reach this goal of getting a certain weight or getting this gut off, or, you know, reversing all these inflammatory parameters in my laboratory.
Exactly. That's why I partnered with an addiction center, and we're doing advanced research, digging into the opiate battle a little more, but we deal with a lot of alcoholism. So if I get a client that I'm looking at him and he's going in the tank, I just say, well, you know, it's time to make a move. You need to pull the trigger, get you over to the addiction center. So that's been very helpful on a lot of occasions. That way, Rob, you and I don't get burned out doing the psychological counseling for 6 hours a week, you know?
Yeah, I can't do that. I don't have time for that.
I know.
And what about all these pre-workout stimulants? I work out several times a week, and sometimes I have these pre-workout powders. Are those any dangerous for health, for testosterone levels? I have no idea, Rob.
I'm not a fan of a lot of the pre-workout. I know the younger guys like to use it. For any of my older patients, I have them avoid it. I do have one particular pre-workout that I like to use, both pre, during, and after. It's from a company by the name of New Ethics. I'm not financially connected to them in any way, but it's the one that I've started using quite a while ago, and I've been really happy with it. You can find it here in the United States. It's New Ethics. But this is what I recommend. I find I don't have many people have blood pressure issues. It works really well in having people like an intermittent fasting. I'll have them drip it during the day, so it kind of keeps the hunger edge off, and it's got a little bit of ketone salt. So that's the only one that I use, but I don't like any stimulants. I don't like things with caffeine, especially with the older, when I say older patient populations, those guys over 40, because it tends to precipitate issues. So I'm not a fan of pre-workouts.
Okay. now that I see you holding your phone, Russ, no problem. But
No.
I had a question. I had a question on that actually, two actually. So I read several times that one should avoid the blue light, the phone next to his bed, of course, for the electromagnetic radiation that would disturb the sleep, but also the cellular phone in the pocket might affect mitochondria health in the testes. What do you know about that, Russ? Do you keep the phone in your pocket of your trousers?
No, I try not to. I pay attention to the research. I also, I work with some white hat code writers and some gamers that spend, 15, 20, 30 hours in front of a computer. And I see the end result of what that causes. Everything from neurotransmitter imbalances to sleep disturbances, imbalances in, melatonin levels. And we try to get them that Vox lighting where they can actually get the light that simulates daylight in their cubicles. But I just think, and we all know that if you're staring at a computer screen at night, it's going to disrupt your circadian rhythm, and we know that. So, the studies are out there. It's just probably another thing we talk about that I try not to overwhelm somebody with. But even the children, before a kid's prefrontal cortex is formed in his 30s, he could be compromising, the neurological architecture by being in front of a screen for 6-7 hours a day. We don't know. This is all blue ocean stuff, guys.
Yeah, I would agree with that. You have a rule in my house: phones stay in the kitchen at night. When I walk in the house, my phone goes on a charging station. I'm done with it. You definitely need to take a break. Try not to have computers and all that blue light in the bedroom. Bedrooms for sleep. And getting to sleep hygiene, really, that's part of it as well too, especially if you're trying to naturally keep your testosterone elevated. Getting to bed early, 10:30, staying inside that circadian rhythm, getting plenty of rest, going to bed in a fasted state, at least 3-4 hours since your last meal, taking your DHEA at bedtime, avoiding the blue light, getting that restful, restorative sleep that'll help boost your levels. So there's lots of things that you can do. Phones, plenty of good studies that have started to show up. I mean, these things were rushed to market before there were ever studies really done. And if you look at Mark Gordon's work, he has plenty of data on the primary and secondary plume of radiation that come off of these and how it passes through the brain and its effect in the hypothalamic pituitary area. And it's pretty disturbing to look at the images, these MRI images of how that radiation passes through. So I try to never talk with a phone next to my head, but I use earbuds.
Mm-hmm. Okay. So I think we went to all the pre-prepared questions I had, and in the chat box we had a lot of good questions from viewers as well for the moment. And one goes really fine with what we were talking about. A question for Dr. Rob. Do you recommend melatonin?
I don't have a problem with melatonin. Personally, I can't take it. It leaves my brain feeling really foggy. So if I'm having trouble with insomnia or not getting restful sleep because of travel and jet lag, I prefer to use CBD oil. However, melatonin can be quite beneficial for many individuals. And once again, it comes down to individual being able to use it or not. So I not that I'm some huge fan. I know there's doctors that are out there that are, but if it works for you, great. If it doesn't, there are other things that you can use.
Mm-hmm. Russ, any experience with melatonin?
Yeah, it's the same thing. It's very individual. I mean, I got clients that feel like they get up with a hangover. I got to pull them off the melatonin. Maybe try some 5-HTP, or let's take a page out of the book, Potatoes Not Prozac, and let them eat a sweet potato at night. See if that serotonin burst will put them to sleep. Because if you don't sleep, that's a form of torture. If you look at a lot of people that were inducted into cults, first thing they do is keep them up for days and cut all the protein out of their diet, and they become real compliant. So yeah, the sleep is like critical. You've got to, and we know now that the sleep architecture is different in everybody, just like our fingerprints. But like Rob said, you've got to get into REM, whether it's a 4-hour blocks or whatever. I work with a lot of shift workers, police, fire, EMS, and I really believe the reason those guys have heart attacks is because of the endothelial dysfunction caused by sleep deprivation. I think that's one of the puzzle pieces, Rob.
Yes, absolutely agree. That second shift, that 3 to 11. Ugh,
Yeah, really. Exactly.
that's horrific. I think it's worse than the night shift, but yeah, not a fan. I used to work in the ER, that 3 to 11. Hated it. By the time I got home, took me in 2-3 hours to decompress from everything that you saw, because the knife and gun club, the shootings, all that other stuff, motor vehicle accidents, and you had to decompress, man. It's like, an hour ago you were in an ER kicking some guy's arm off the floor, and now you're home and you're trying to like cool it, trying to relax. And so it'd be 1-2 o'clock in the morning before I finally get to bed. Then your brain's going, right? Did I do the right thing? Because there's something else I could have done. I don't know. And then next thing you know, you're up and you got to do it again. Yeah, I hated that shift.
No, good for you, man. I'm glad. That's probably why you're still alive. You stopped that, and I stopped being a paramedic. Thank God. I think that's why we're here, Rob. I swear to God.
That's kind of a thankless job, a job that's definitely needed, but those men and women don't get the praise that they deserve.
Rob, I got some interesting research just to want to share with you since you get the shift work. I don't want to preach to the choir, but a lot of new research, we're looking at the fight or flight response in the amygdala and being over, expanding because of the type of stress that you're under. And then it's pulling back on the prefrontal cortex executive function, which I think is interesting because, I always study those cop shootings where one guy gets out of the car after a 30-minute chase and all of them fire their weapon. That's like, they're not trained in that. You know what I mean? I think there's a couple of situations I've been looking at in different parts of the U.S. that the high functioning people that are on emergency scenes, emergency room docs, I think their whole brain structure changes.
No, I believe it. There has to be some adaptation.
Mm-hmm. Okay, next question from the chat box. I don't know why someone would ask, but what about DECA as a thing to hormone replacement therapy? Rob? Not a good idea, probably.
No.
Okay, I don't know why someone should ask that. Then another question. What about should thyroid be optimized along with TRT? I believe so. And I believe it should be, the questioner says, but I would like more details on why. And
well, once again, that's individual. And if it's clinically indicated to use thyroid medication, then absolutely. But many times when you look at thyroid function, you'll often find that it's a vitamin and mineral deficiency, usually from a gut problem, not necessarily that they actually need to be on thyroid. So, and once you correct those big deficiencies and get their gut, get the yeast knocked out and get some of those neurotransmitters functioning appropriately again, and then get the vitamin and mineral supplementation, particular vitamin D. People are so vitamin D deficient. Often you'll see that reverse T3 drop and then the free T3 goes up. So, yeah. If it's clinically indicated, yes, but not just to take it for the heck of it. Okay,
Russ, you agree, of course?
Yeah, I think, everything. We've got to look at nutritional deficiencies first. Everything is interconnected. So like Rob said, you don't just want to go to guns first with the medication when we know that iodine and selenium and the B vitamins are all interconnected to a good functioning thyroid. So again, it's very personalized. So the pharmacies I work with have about 100 different dosages for T3 and T4. Why? Because doctors have, they need that range while they're, it's trying to find like a radio station in some patients. You got to keep dialing it back, dialing it forward, before you nail it.
You just dated yourself, Russ. Those are the old transistor radios, right? You hit the button, you got it close, then you took the dial and you had to move it back and forth. Exactly. Those were fun, actually. I miss those radios. Those were.
Yeah, me too, man.
Okay, so I think the next one is a good question. What is the highest total testosterone and free T you have ever seen in an optimized TRT patient, Rob? Is that important? I don't think so.
No, not in a medical legal case. It'll definitely be important. I'll tell you that much. But from a clinical standpoint, no. What do you want the number to be? take a shot and take the labs. Do it at 5 hours, do it at 12 hours, do it 20 hours, whatever the number, whatever you want it to be, just to change when you draw the labs, you'll get whatever number you want. So to me, it's not irrelevant. From a medical legal standpoint, it can certainly be relevant if you have a case that's not turned out well. It will definitely be used against you by the attorneys. That's for sure.
Right.
So, yeah.
So you can't have labs going over 1500 total testosterone.
I wouldn't say that, but that's a whole nother subject. That's really for physicians.
Really?
Us. Yeah.
Okay, I agree. You shouldn't chase numbers. Then someone asked how to optimize all day low cortisol, and is there a connection to the thyroid? I guess, Russ, you already talked about that in the last podcast.
Yeah, I think we have to look at, the HPAG axis. I deal with the outliers, war veterans, emergency personnel that have been in highly stressed environments. And we check their cortisol 24-hour sample and it's in the tank or it's still remaining high. So the treatment protocols are going to be dictated based on the biochemical individuality of each person and where they are in their life. Are they going back into the war zone? Is this guy going back undercover? Or is he going to be able to take 3 months off? And I think that's going to dictate the treatment for my docs or for, like, if Robert runs into somebody like that, you really got to get a good backstory on where these guys are, because thyroid and cortisol and the adrenals, they're all part of the HPAG axis that really gets compromised for my outliers, when they're in the tank.
You agree, Rob?
Absolutely. It's all interconnected. You can't treat one system in isolation.
Okay, then a good practical question. How to deal with non-compliant patients, Rob?
See ya.
Yeah, bye-bye.
Bye. Listen, if somebody doesn't want to be here, I'm not going to twist their arm, right? I'm not going to force somebody to be here. And sometimes relationships don't work out. Sometimes I'm not the right doc for them and they're not the right patient for me. And that's okay. I can't fix the world. Russ can't fix the world. Sometimes, there is a seat on every bus for every ass. It just might not be on my bus. So, but with the non-compliant ones, I'm not going to force somebody to stay with me if they're non-compliant, because it's frustrating for me. It's frustrating for them.
I just say for the longevity of the physician, because the guys here, there's so few and far between. If you have a pain in the ass that's not working with you, cut them loose, just for your own health and your family's health, right? Yeah. Come on.
Yep. And a patient coming to you for the first time, he's overweight, having a shitty diet, doesn't work out or exercise, and he asks to be optimized. Do you pressure him first to change his lifestyle before you treat?
I don't pressure anyone, and I'm sure Russ doesn't either.
Never. Are you kidding me?
And that's a waste of time. If they're here, generally they've already started to make changes.
Right.
It's not working. They've been in the gym, they've cleaned up their diet, they're drinking more water, they stopped drinking, yet nothing's changing. They're not losing weight, they're not sleeping better, and they're frustrated because they've been doing this for a month, sometimes 2 weeks, about a month, maybe 2 months, and they're like, I need help. I'm not getting where I need to be. Those are generally the types of patients that we get. Or something scary happened. A brother died, a father died, a good friend had a heart attack, stroke, and it scared the living crap out of them. And they're like, I got to fix my ways before this happens to me. So it's usually some motivator, some kind of fear, some kind of pain, whether it's emotional pain, physical pain, spiritual pain, some kind of pain that's brought them in, that wants them to make a change. And so they're usually already motivated. They just don't know how to get there. I very rarely, like one time 4 years ago, I got a guy that came in, literally wanted to have an argument about every little thing that I suggested. And I asked, well, why are you here in the first place? I don't have time to sit here and convince you to do these things. You either want to, he actually said to me, smoking doesn't cause lung cancer. And he could prove it. And with that, I was like, yeah, I think you're in the wrong place, and we're not going to be a good fit for one another if you think smoking doesn't cause lung cancer. If you can't even get the basics, right? If you can't even stop smoking, stop eating tons of processed food, but limit your alcohol, start getting better sleep, and start walking every day. Those are kind of the basics. I mean, walking is one of those underrated things, but if you actually look at the studies, walking 20,000 steps a day or more significantly decreases your risk for heart attack or stroke. I mean, profoundly. And there have been different studies done at different tribal groups. One, the Chamani Indians in South America, 80% carbohydrates in their diet, 80% carbs, yet the lowest rate of heart disease. And they fast CT scan these individuals, men in their 70s and 80s, and had zero evidence of cardiovascular disease. And the only thing they could really attribute it to is all of them were walking more than 20,000 steps a day, despite their high carbohydrate intake. Now, their high carbs were root vegetables. So it wasn't bad carbohydrates, but mostly root vegetables and walking.
Okay.
Stephen, those guys that you just talked about, like, a lot of them, you know, I treat them like addicts when I get those people. I mean, I have a team that takes care of them. I don't do a lot of one-on-one, but a lot of them are addicted to the food and to the carbohydrates. I mean, carbohydrate addiction is real for some of these guys, and also from a behavioral side, they've been hoodwinked, lied to, and bamboozled because years they said they were fat because they ate too much. Nobody thought about metabolic syndrome. So they've been being fed bad information for years, and I meet somebody like Rob and me, and all of a sudden, you know, they're pissed. I get it, you know?
Yeah. So we have two more questions from the chat box, then we're done with it. Someone says, I'm in between docs and he has to stop testosterone temporarily, and he's using Clomid in the meantime. Can he sustain his testosterone levels till he gets back with the doctor for the testosterone? Rob.
That's a yes and no kind of question. I mean, good thing he's on clomiphene, but that can take months. As we all know, that's not something that's immediate. So I don't know why he's on therapy, but taking a break from therapy, I would discourage it. If he was put on therapy in the first place for a valid reason and a good reason, I would get back on therapy. I wouldn't be taking a break. You know, once he gets 2 to 3 weeks out, he's going to start to feel it. So,
okay. So the last question there was for Dr. Rob. What is the influence of testosterone on Peyronie's disease? You have any experience with that?
That could be good and bad. For people with Peyronie's disease that have painful erections and they have decreased erectile quality, and now you add testosterone in and you're engaging those androgen receptors and they start having early morning erections again, that can be quite painful. So it can be helpful, but it can also be painful if it's not going to correct the Peyronie's disease. That needs to be treated. You can use extracorporeal shockwave therapy, PRP therapy. We're now just starting an IRB with organocell, and we're going to start looking at using exosomes in the plaques. So, and there's other therapies as well. But that plaque needs to be resolved to help with the Peyronie's. But if they're having erectile quality issues and you add testosterone, and it can be painful.
Okay. Anything more to address to that? You have experience with erectile dysfunction?
Yeah, same thing. That's a tough one, really.
Okay. So that's for the questions from the chat box. And then we had this last section we're doing each time, the bro science section. You both are all these forums as well. You read all this funny stuff, this bro science. So I ask you, have you read something the last week or weeks or heard that you really wanted to debunk because it's a shitty piece of information, Rob?
I don't go on those forums because I don't have time. Every once in a blue moon, I was in the hospital for a day and was bored out of my brain. So I went on one of those forums. I can't remember what I read, but it's one foolish statement after another. And a lot of individuals, well-meaning, trying to help other individuals through their issues, which quite frankly can be comical and dangerous. I would suggest that you work with a qualified physician who's been doing this for a while. And there's more and more of us out there. It's not as hard as it was 10 years ago, 20 years ago. There's different docs around the country and around the world that are conscientious about what they're doing. Yeah, off the top of my head, I don't, but I remember seeing some really foolish stuff that people were doing. So, oh, I know what it was. Somebody went to like one of the farm supply stores and got equine steroids and wanted to know if they could inject it, and if so, how much they should take. Yeah. All right, go ahead, knock yourself out.
Okay, Russ, you are in the forums. I know you try to help some people there.
Yeah, I deal with a lot of bodybuilders that went south, so I follow some of these forums just to see what's trending, see what the hot drugs are in the market, see who's using 16 IUs a day of growth hormone and getting diabetes and things like that. In my area, it just seems to be helpful, so I kind of keep an eye on it. I'm like Robin, I don't judge anybody, I listen, but when somebody gets in front of me or I spend 3 hours with somebody, I got to drill down really quick and get them answers,
Yeah, of course.
Probably the one thing that I've seen lately that I'm a little bit concerned about is individuals using these peptides with DAC, the drug activity complex. I would strongly suggest anybody using any peptide with DAC to stop. In the last 6 months, I've seen 3 cases of diabetes insipidus with DAC. So it's an association. It's not a causation, but it's certainly interesting that I've seen that. So if you're using any peptides, use it without DAC. Mm-hmm. Right. I think that constant stimulation of the hypothalamic pituitary tissue is not a good idea.
Yeah, probably. And that's like MK677, for example, you're talking about?
Yeah. So CJC 1295, ipamorelin. You can get it with and without DAC. You want it without DAC. I wouldn't be using the drug activity complex, which extends its stimulation time. So, and like I said, I've seen 3 cases now. Mm-hmm.
Okay. One more question comes in that I really think is interesting. Would supplementing with L-carnitine be beneficial for TOT, as it is purposed to increase androgen receptor density? Have any idea about that, Russ?
I think on the cellular level, if we look at the mitochondria, I do a lot of mitochondrial testing, that we know that carnitine helps fatty acids pass into the mitochondria to create ATP. So for me, the most biologically active tissue with high amount of mitochondria are the heart and the brain. So yeah, I think we could test for L-carnitine to see if there's a deficiency, because there's also a range there. But with my heart patients, I would just go ahead and use it because of what it's beneficial that way at the level of mitochondria. I don't know if Rob agrees or whatever, but that's kind of what we do.
Okay, Rob agrees. So we're at the 1 hour mark, guys. So I think we should round this up here, respecting your time. Thanks so much for helping us out, Rob and Russ. Maybe you can explain to the viewers or patients how you can be reached if they would want to work with you, Rob. How can you be reached?
Yeah, the simplest way to find us is at drrobdo.com or also Renew Health, RENUE health.com. You can find us online.
Okay. Russ, where is your center?
I'm in Orlando, Florida, and you can see Scala Precision Health. I'm in my hometown of Winter Park, and then I started the Russ Scala YouTube channel just to educate people on how TRT may affect MS, depression, how it may affect Alzheimer's, how it may help with remyelinization. And I got some pretty cool stuff up there. So I'm trying to always keep that trending. I'm doing the next video on my channel about Scott Kelly that spent a year in space, metabolically what happened to him. So I think that should be cool.
Okay, thank you so much, both of you, for your time. I think we helped out a lot of guys with professional information. So thank you so much, guys. See you next time.
See you, Rob.
Thanks. Take care.
Bye.
Okay. Bye.
Thank you.